Hello and welcome to the new episode of the EuroOnco platform. We are here in Budapest. We are attending the EuroOnco 24 meeting. It is a very, very lively meeting, and we have the pleasure to have here today with us Professor Geert De Meerleer, one of the top experts in the field of radiation oncology, based in Leuven, Belgium. Thank you, Geert, for being here. And so radiation therapy now is part of the multimodality treatment for many, many patients with prostate cancer. So there are many, many questions, and I will start with the first one. We discussed in multiple sessions and case discussion today. So which is the role and the safety of radiation therapy in a patient with de novo metastatic hormone-sensitive prostate cancer?
Okay.
2024.
2024. Thank you for that question. The role is quite substantial in that sense that thanks to the huge efforts in UK and the Stampede trial, there's no level 1 evidence that radiotherapy to the prostate or to the prostate and the pelvic nodes, this is something which is not so important, but certainly to the prostate, in case of de novo, low volume metastatic prostate cancer, it improves overall survival. And which is nice that the hazard ratio of the improvement of radiotherapy, 0.68, is the same as of abiraterone added to. So it has certainly its place over there, without any doubt. The nice discussion today was, and very lively as you said, is if you go for a combination of ADT and abiraterone or APA, ENZA, whatever, do you still have to add radiotherapy? Because then you have a triple treatment. But I must say that most of the experts in the field from worldwide have said, go for the triple. So a second thing, and this was quite surprising, in the PEACE-1 trial from France, which has now already finished its recruitment for years, so the results are quite updated. Alberto Bossi, he presented not so long ago at ASCO GU, surprising results. I was positively surprised that radiotherapy to the prostate in this setting also significantly postpones the advent of urinary problems caused by the tumor. Of course, you can induce urinary toxicity, but apparently the fact that you postpone the real issues due to tumor growth and postpone the urologic toxicity is very important and is significantly better. What is the safety with modern radiotherapy? I think you can discuss on the schedule. I think that you go for hyperfractionation like they do in UK. Stereotactic body radiotherapy in this setting is not studied yet. So let's go for hyperfractionation. You have the typical acute toxicities, urinary necturia, increased frequency during the day, sometimes a bit of dysuria. And in the first years after treatment, mostly it remains to urgency in, let's say, 10 to 15% of the patients. But when they grow older and they keep living longer, thanks to all the new products, sometimes they have to take extra medication. And what we see, people need antico, and then they have a risk of hematuria. So for urinary toxicity, it's very important to follow your patient more than 10 years when he's alive. Not say after 5 years, it's okay, that's too short. But it's well tolerated. I mean, I think that most of the patients, 80% have grade 1 or no toxicity. From rectal point of view, what you see sometimes is also urgency, and with fecal incontinence, which is for me, from a social point of view, the most devastating one. But then you can give the patients, when they go to a social event, for instance, a marriage, you give them loperamide preventively. But severe toxicities like blood loss and obstruction, you don't see anymore. So it's safe and it's level 1 evidence.
Okay, thank you. And when we shift to the next setting, yeah, there were many discussions. So how to use the radiation therapy in the setting of the oligorecurrence, so after a local treatment, right, and mainly for the low volume, because these are mostly the patients that we are seeing in our daily practice. So it's again efficacy, quality of life. Are these treatments safe even when administered with all the new generation of systemic treatments?
This is my favorite item. So first of all, SBRT stands for stereotactic body radiotherapy, so it's extracranial metastatic disease. I have to focus, so brain mets are never into this discussion. It's important for the people who are listening to us. Metastasis-directed therapy can also be metastasectomy, so urologists also have their role. You're right, we do it for what we call oligorecurrent prostate cancer, which is defined, let's say 10 years ago, as having 3 metastatic spots on choline PET-CT, because this was the best we have. Now with PSMA PET-CT, we go to 5 lesions. And then you go for stereotactic body radiotherapy, which means that you deliver a very high dose at a very low number of fractions, for instance 3 times 10 gray, which is very high dose. It's more than 70 gray on the prostate. Yeah. It's safe, but you need PSMA PET as imaging tool. You need very modern radiotherapy planning systems. And you need, without any doubt, what we call image-guided radiotherapy, meaning that when the patient is on the treatment table, you do a CT or even an MRI when you are even more advanced, but only a few centers have this already, and you check whether the location of the lesion that you want to treat 100% corresponds with the lesion that you planned. So it's the accuracy of 1 millimeter. Why do we do it? Because historically there were those 2 top American colleagues 30 years ago, Hellman and Weichselbaum, who said, yeah, maybe this low volume metastatic disease is a separate disease status. Maybe we can even cure them with an aggressive behavior towards the metastatic lesions. So a lot of retrospective analyses have shown that you can postpone the need for palliative ADT with 5 to 7 years. I think it's substantial. Or palliative ADT and ARTA, because that the metastatic, polymetastatic free survival at 9 years is 90%. So this is huge. Of course, the opponents, they say there's no randomized evidence yet, but we are working on this in several trials worldwide. In my country, it's the SPARKLE trial, randomizing between SBRT alone versus SBRT plus 1 month of ADT, radiosensitizing effect, which has been proven due to the testosterone receptor, but we shouldn't go into detail, it's another item. Or the same with 6 months of ADT and 6 months of ARTA. This is a study running. Meanwhile, if you are not able to put a patient in a study, I think that going for SBRT or metastatic directed treatment in oligorecurrent disease, you should at least consider for your patient, because by postponing the systemic treatment, you postpone the toxicity, and you are a top urologist, you know it better than me, but apart from the sexual issues, you see a lot of emotional lability, a lack of physical activity, voila. And I think that this is underestimated. Patients, it's maybe not a hard endpoint is ADT-free survival, but patients are happy with it. That's point 1. Point 2, theoretically, by using SBRT, you do not cause damage to the DNA of the prostate cancer cell immediately, but you cause damage to the vasculature around. And prostate cancer cells have far less, repair mechanisms to that. So you might also kill the very bad cells, leading to a hypothesis that afterwards, when you need systemic therapy, it will work better. That's an hypothesis. 3, apart from the quality of life, because the patient does not need systemic treatment, it's nearly atoxic. I think that 90 to 95% of patients do not have any chronic toxicity. Apart from, of course, a lesion that is very close to intestinal loop, you might have some diarrhea, but generally speaking, most of the patients do not have any toxicity. So I always think it's very difficult to defend 2024 and the upcoming years to run randomized trials in oligorecurrent metastatic disease without having metastasis-directed treatment as a standard. That's my opinion.
Thank you very much for this overview. And of course, we are seeing more and more frequently in our practices the administration of the SBRT, and we know for sure that it's very, very safe, and of course there's the benefit of delaying other lines of therapy and the associated toxicity. Thank you very much, Geert. Thank you for those at home who are listening and watching us, and stay tuned for the next episode.